Assalamu alaikum everyone. I'm Dr. Sadia Noor and I'm your coordinator for today's lecture. And I welcome all of the participants and especially you, sir, to this lecture series. And I would like to request all the participants to keep their mics muted during the lecture. And if you have any queries, any questions, you can comment in the chat box, and we will address them after the speaker has finished the talk. And reminding one more thing, that this mode of delivery of the lecture is in the English language, and all the conversation will be in the English language because we have participants from all over the world. Let me introduce you to Dr. Shahid Rasool Dar. He is assistant professor anesthesia and pain medicine at Department of Anesthesia at Gurki Trust Teaching Hospital, Lahore. He has been associated with anesthesia. He has been practicing anesthesia and for 20 years, and he has special interest in peds, ICU, and ops anesthesia. He is also a member of the European Regional Society of Anesthesia, member of PSA and International Society of Pain. Sir, I welcome you. And the topic of today's lecture is recent updates on COVID infection. Please, Liz.
Thank you, Dr. Sadia, for introducing me. Bismillah ar-Rahman ar-Rahim. First of all, to begin with the name of Allah. So today my topic is anesthesia for the emergency cesarean section. My introduction is already done by Dr. Sadia Noor. I am assistant professor at the Gurki Trust Teaching Hospital, Lahore Medical and Dental College, Lahore. And today the learning objectives of today's lecture is the burden of cesarean section, classification of cesarean sections, managing the burden of cesarean sections in the low resource settings, and I will go through the literature review of the different anesthesia options available for the cesarean section, emergency cesarean sections, and timeline and guidelines for the anesthesia. And then at the last is take-home message. I have no conflict of interest to declare. And this is my institute. This is Gurki Trust Teaching Hospital along the eastern border of Lahore, along the Wagah border between India and Pakistan at the border. And it is serving the poor people since 1995. And it has one of the best spine and orthopedic center. Is the first orthopedic and spine center in Pakistan. Apart from all other specialties are working. Today we are talking about cesarean section, emergency cesarean section in anesthesia options. And we are also have a very good and effective department under Professor Dr. Fozia Ambar Qureshi, working as a head of the obstetric department. First slide. First of all, we go for what is the cesarean section burden. And for cesarean sections, babies must be born. And in the next 4 minutes, there are 1,000 babies are to be born in the whole world. And you can see in this slide, the most of the population was born in the Asian countries and then African countries. The India is leading with 172, and now the most of the African countries, they are having the most of the birth rate, but most high birth rate in the African countries. And the more babies are born and the more cesareans are going to be there, and there will be more future for the obstetric anesthesiologists, but there are more complex cases are developing with time, and there are more strategies to resolve. And every 2 minutes to prevent these, we have to proceed for the optimal cause of the emergency cesarean section. And this slide shows the anesthesia workforce in Pakistan. We have only 1.48 anesthesia workforce available for the 100,000 population. It is very low as compared to the other developed parts of the world. But in Pakistan, India, and you can see in African countries, we have only 1.4 qualified anesthesiologists available for the 100,000 population. This is a very low ratio. Why I am talking about this? Because there is a very high rate of mortality is related with the percentage of the qualified anesthesiologists available to cater the emergency cesarean sections. Sorry. Slides. This is, and now this is the maternal mortality rates. Slides are moving now, I think so. This is the maternal mortality rate 2023. In Pakistan, the maternal mortality rate is 155, and in other parts of the world, it is very much high. In Pakistan is also the ideal. Sorry, the slides. Just wait, I am having some issue with the slide. Nigeria is the top death per 100,000 live births, and then the Pakistan is in between 155. What is the goal? Slides are slowly. Just 95% of the maternal deaths in the will occur in the lower middle income countries, and 84% of them are preventable. The most common causes in the low middle income countries are the hemorrhage, infection, hypertension, unsafe abortion, and delivery complications. The WHO developed a sustainable development goal of less than 70 deaths, maternal mortality rate less than 70 per 100,000. Now we will discuss what are the different causes of maternal mortality. There are, if you go through this slide, on the left side of the slide, there are the maternal causes which are decreasing, and these are usually the hemorrhage is decreased, the phenomena decreased, but there are certain other new emerging causes of the maternal mortality, such as the cardiovascular conditions, because most of the cardiovascular conditions are early treated, and the women become fertile and they go into the pregnancy, and then more and more cardiac cases are being observed in the obstetric. And the cardiomyopathy is also, since 2010, the ratio of cardiomyopathy is also increased in the obstetric 40s. And the cerebrovascular accident is also increased. In other conditions, these are some direct conditions and some indirect causes. Apart from the direct causes, some indirect causes, the psychiatric illness also taking a major part in the post-maternal death. Now, next we are going to categorize the category of the cesarean sections. We are usually discussing in this scenario category 1 and category 2. The category 1 is the immediate threat of the life to the woman or fetus. For example, in suspected uterine ruptures, major placenta rupture, cord collapse, fetal hypoxia, and persistent fetal bradycardia. For category 2, maternal fetal compromise, which is not immediately life-threatening. Usually, these two categories are most frequently presented in emergencies. And the category 3, no maternal or fetal compromise, but needs early birth. Category 4, the birth times to suit women and healthcare. These are usually the elective cesarean section. Some institutes also categorize in cases of red, orange, and green, like triage. They categorize the emergency cesarean section as red, and the urgent as orange, and the other as green. These classification is according to the NICE guidelines, and they also recommend CM2 delivery of the fetus should be less than 30 minutes. And for the category 2, they recommend it must be 75 minutes.
Sir,
Some
there is some
circumstances,
problem
but
with
these
your
are
voice. Sir, excuse me.
Gigi, yes?
Sir, there's some problem with your connection, I guess. We can't hear your voice clearly.
You are not hearing my voice.
Clearly, sir, it's not clear. Sometimes it's there and sometimes it's not.
I may use another mic. Now you can hear me or not?
Yes, sir. Perfect. Thank you.
Now you can hear me? Yes.
Yes.
This is the decision to delivery interval. You can see here for category 1 and category 2, when the qualified obstetrician decides that I have decided to go for the mode of delivery is the cesarean section. The team is alert, the patient leaves the labor room, patient enters the theater, and the patient transferred to operating table and anesthesia is given, and skin preparation and draping and skin incision, uterine incision and baby lever. This all timeline should be within 30 minutes for a category 1 and 75 minutes, but these are the ordered times, but may take more times, but usually this time was more stress in the anesthesia time. Anesthesia time, if 1 or 2 minutes are delayed, then there may be a lot of problem in the OT. But this all must be quickly observed to get the baby delivered. What is different in emergency cesarean section relative to the elective cesarean section? It is a high stress is involved because the timeline is involved. There is a lack of time. More experience is needed, but usually in the lower middle income countries, usually the novice anesthesiologists are serving in the obstetrics units. Self confidence of the anesthesiologist, quick decision making is also very important. Whether you are going for regional or general anesthesia or some other options you are going to consider, and the mostly stress involved is the obstetrician is going pressuring each and every, because he or she knows that there is a timeline is very short for the baby if you discuss with the obstetrician. This is American ASA guidelines for the obstetric anesthesia. Obstetric anesthesia they developed in 2016, and they decided that decision to a particular anesthesia technique for a cesarean delivery, it must be dependent on few things: some elective or emergency cesarean sections, preference of the patient, and judgment of the anesthesiologist. Considering selective neuroaxial techniques in preference to GFR, most of the cesarean deliveries they are usually recommended. Outcomes associated with anesthesia technique for cesarean section in lower middle income countries. Secondary analysis WHO survey, it shows that the neuroaxial anesthesia is associated with significantly lower odds of maternal deaths, maternal near misses, severe maternal outcome as compared to, and very less admission to intensive care units. General anesthesia option guidelines for the cesarean section, they also show the indications for the general anesthesia is the maternal refusal of regional anesthesia, failed regional anesthesia, any contraindication to regional anesthesia, thrombocytopenia, or uncontrolled hypertension, or from blood loss, or any clinical urgency at the discretion of the anesthesiologist. Why are we so much aware of general anesthesia in emergency cesarean sections? This is the different risk for general anesthesia. You must know accidental awareness, complication associated with aspiration and failed intubation, greater maternal and neonatal sedation, increased risk of poor uterine tone and blood loss, impairment of early breastfeeding and maternal and neonatal bonding, and increased risk of postpartum depression and suicidal attacks. This is the new checklist which added by NHS after the 2021, because this must check that this objective checklist, rapid sequence induction checklist for general anesthesia must be checked before and like after the WHO checklist to proceed for the general anesthesia and obstetric patient. You must, there is a difficult airway or not, you must give any prophylaxis of the aspiration, optimize position, check IV access, ask the surgical team to prepare the abdomen for the knife to skin incision, to decrease the knife to skin incision. Is there any require any monitoring displayed, and any airway alternative equipment, the laryngeal mask airways, the Macintosh, the video laryngoscope, supraglottic airways should be available before proceeding further general anesthesia in an obstetric patient. What is your plan A and B? What is the difficult area trolley, and how will you call for if there is a help needed? Either you call early or where you want to call. This study is again in maternal and neonatal outcome of spinal anesthesia and general anesthesia in emergency cesarean section. This study was done in Bangladesh, Pakistan, and Bahrain. And this study also shows that the general anesthesia and regional anesthesia can be given on account of maternal and neonatal outcome and mortality. Both techniques can be utilized safely depending upon the discretion of the anesthesiologist available and assessment of the decision of the obstetrician and the anesthesiologist. Now we will come into the high income countries where a study done, Mowbray study was done in UK and Ireland. It is really it has investigated the death during 2019 and 21, published in 2023. There are usually 10 women per 100,000 died during pregnancy up to 6 weeks after the birth of the or end of the pregnancy. What they found in the Mowbray study that there is wide variety of ethnic variation in the maternal mortality. The white women have very less rate of maternal mortality. Asians have double the rate of the maternal mortality, and the black woman has 4 times more than the maternal mortality. And they also studied that there is a least deprived areas and the most deprived areas. The most deprived areas has double the maternal mortality rate as compared to the least deprived areas. So the low income settings may exist in the high income countries. What are the different causes of the maternal mortality? When they in this study they found that in this study, apart because this study was done in COVID period, there's a lot of deaths due to the COVID in the pregnancy ladies. But apart from the COVID, there are the cardiac diseases, which are the number one associated diseases, and then the thromboembolic phenomena, and then the third most common was the psychiatric diseases. These the diseases are on the upsurge in the high income countries as compared to the low income countries. But lower income countries, usually there is data is not evident, but they are now happening in both low and mid high middle income countries, apart from other conditions. They also found that deaths related to the anesthesia now decreased to less than 1%. Global and regional causes of maternal deaths 2019 to 2020 WHO systemic analysis. They also study to achieve the goal of the SDO Sustainable Development Goal of 70 per 100 million. They also found the different causes of maternal mortality, and they also found that in the lower middle income, mostly the hemorrhage is the cause of the, and there is the indirect causes like psychiatric or the cardiac diseases, where these are usually mostly second most common cause, and hypertension is the third most common cause of the maternal mortality. Due to the anesthesia, this study also shows the maternal mortality is less than 1%, and average proportion of deaths due to suicidal. Actually this one is a global study, and they found that in the high income countries, especially in the New Zealand and Australia, they found 26% of suicidal deaths from in the due to the postpartum depression. Now we will some factors which are important in the low resources settings, maternal mortality and morbidity rate. First of all, what are you going to induce? Whether you're going to GA or regional anesthesia, the GA has 5 times more complications, airway aspiration, hypoxia complications. Spinal anesthesia is safe, but it also depends on a lot of availability of the vasopressors, lack of other pumps, and the difficult resuscitations in these areas. Additional protocols, there is really missing the failed spinal and the high block protocols, monitor basics, really pulse oximetry, the monitor deficiency, rescue any airway algorithms, and ensures vasopressor availability and oxytocin and availability. There are some other systemic drivers which must be there. Like there is the presence of the qualified anesthesiologists, non-physician providers. Usually, in the low middle income countries are done by non-physician providers. There is a lack of training. There is a workforce crisis. Infrastructure gaps are there, and there is emergency protocols. They are deficient in the lower middle income countries. The neonatal outcome is also dependent on the neonatologist available to resuscitate the child, and the neonatal and the training and the facilities available for the care of the neonate. Now, if we are going to proceed for GA, this KTS, this is a knife to skin incident time decrease. You must plan 2 things at least before planning for GA, that you are going to induce GA in this patient. and you must prepare the kits of the patients, and then you must also discuss with the obstetrician that if there is a evidence of failed intubation, then whether we're going to awake the patient or we're going to proceed. These two things must be done, discussed before proceeding for GA in these patients. Other factors under GA, which are these are airway factors, these are the patient factors, environmental, the anesthesiologist factors, and the uh, equipment and the situations. A patient is either labeled as difficult or not. Anesthesiologist is less experienced or working alone, remote area, equipment, variable equipment, and that is category of the Syrian section, whether it is category 1 or category 2. In GA, this is a new thing, high flow nasal oxygenation. This is also depend upon the your work in which setup you are working in. This is usually available in high income countries and good resources setups. Hand free oxygenation is there, and there is depending upon the training cost, and this is the pros and cons in that depending on the cost and setup in the emergency. How it will take some time to set this system. GA is also associated with most postpartum depression. This study was presented in ESTA 2025. This study was done in Canada, and this also found that GA is associated with 38% increased risk of postpartum depression and in 45% increased risk of. This is again a cause of death in the high income countries. Mother-infant bonding, this study also shows that mother-infant bonding is less in GA as compared to spinal anesthesia, shows superiority. Now we are going to discuss the regional anesthesia options. These regional anesthesia options depend upon the education, the healthcare system, and the healthcare settings. The epidural analgesia, there must be a trained anesthesiologist provided who is expert in epidural analgesia will be there if you want to proceed with epidural analgesia. Spinal analgesia, better than nothing, but sometimes limited duration is a barrier, and economical and cultural and religious, and sometimes the situation is not allowing for the situation of the patient is not allowing for the regional anesthesia, then you have to proceed for the general anesthesia. Now, then, when there is so much problems with general anesthesia, there are some studies which are done that what is the time to decrease the delivery to decision to delivery interval. So there is a study done in 2013, speed of spinal versus general anesthesia in category 1 cesarean section. This includes simulations and clinical observation-based studies. And they found the time for spinal anesthesia was 8.50 minutes and general anesthesia take only 2 minutes. So there's a lot of time difference, especially in category, which is a life-saving for category 1. Now here comes the rapid sequence spinal anesthesia for category 1 urgent cesarean section. This is a case series which is one by Cancela. They also study that decision to delivery interval decrease, and they usually perform spinal within 2 minutes, and time to the satisfactory block take 4 minutes, and total time was 8 minutes. They also there are few case series which are showing that rapid sequence spinals can be more or less equal. If you what are the different components of rapid sequence spinal, we will discuss the next slide. What are the different components of rapid sequence spinals? When the patient arrives in the OT, the simultaneously intravenous access is being maintained and monitoring is attached, and pre-oxygenation during the attempt of the spinal was continuous for rapid conversion to GA if needed. Adopt non-touch technique, gloves only, no gown necessary, skin prepared with a single wipe of chlorohexidine. Consider omitting intrathecal opioids if this add unnecessary. Usually opioids are missed, and consider increased dose of hyperbaric bupropion, usually 11 to 12 milligrams according to the height and body of the weight, but you can go up to 15 milligram, but it all depends, varies with patient to patient and the condition of the patient. Surgery is consensus block is at the level 10. When there is a level 10, T10 level, you can start with the surgery and all equipment and ready for conversion to the GO. These are the different steps of the rapid sequence spinal which were described in the previous study. And there is another study which also compared the rapid sequence spinal and general anesthesia in category 1 studies. This is the Bhattacharya study. It was done in West Bengal, India. And this study actually claims that the time for the general anesthesia was total maintenance of anesthesia and start of surgery was 178 seconds. And then in the he also claims that when there's a rapid sequence spinal anesthesia, it takes only 169 seconds to start. So this is favoring the rapid sequence spinal in category 1 sections. Perinatal outcomes with epidural and general anesthesia. This is also again a study favoring the epidural anesthesia has associated with a negative impact on neonatal and maternal outcome as compared to, and they may show if your patient is having an epidural anesthesia for labor and you proceed it for the category 1 cesarean section, induce it with epidural, that epidural, it will have short delivery to decision to delivery interval. Does any mode of anesthesia affect postpartum hemorrhage? This is also in study. This study 80 manuscripts and more than 12,000 women were studied, and they studied the higher blood loss associated with neuraxial anesthesia. There's another study favoring neuraxial anesthesia in emergency cesarean section, especially the patients with placenta previa. They also studied the patients. Is published in 2025 that GA is that in milder forms of placenta previa, the regional anesthesia can be done with safety. But there are certain different causes of general anesthesia. This is an again study, which is the placenta accreta spectrum study, and this also compares in comparison to GA cesarean delivery with neuraxial anesthesia may be appears to be associated with reduced intraoperative blood loss, back red blood cell transfusion, operation duration, and postoperative hospital stay. But this all depends upon the condition to condition of the patient. There are some other postoperative problems are associated, risk of the maternal adverse events are associated with emergency vascular lacunae with the placenta or hypervascularity of the uteroplacental margins. This is an important cause now. This is intraoperative pain during cesarean section, which will convert the from cesarean from the regional to the general anesthesia, and it will further increase the mortality of the patient. Incidence is nearly 70% on the pooled side and into 3. This must be managed with care, it must be reassessed, and it must be at least know that quality of the anesthesiologist to assess and to differentiate whether it is an actual pain or it's just feeling, and then counsel the patient about the pain and then proceed. Either if there is any doubt, then you can proceed with the GA. This breakthrough pain index is very important. This is usually used as a quality index. When we next discuss the different quality index in an obstetric anesthesia units, then we will come to the breakthrough pain management. The breakthrough pain conversion to GA in the emergency situations. Choice of anesthesia for category 1 cesarean section. Now, this is a situation when the patient is become with an anticipated difficult airway as a category 1, and you have to decide whether you're going to for GA or regional anesthesia. Then this is a study, and they study design, decision tree, data gathering, and calculated cumulative probabilities, and what they found when you use a category 1 cesarean section in which the difficult intubation is anticipated, use video laryngoscopy, it has the minimum time, 100 seconds you can make the patient available for the surgery. But a ventricular intubation, it will take 7 to 11 minutes, and the spinal anesthesia, it will take 5 to 7.4 minutes. So in difficult cases, video laryngoscope is the choice of anesthesia if you are expert. And these are study references. Now we are going to discuss the guidelines, which are the different guidelines available, and the quality index. The quality index usually are made on these 6 elements. This process is safe, effective, patient-centered, timely performed, and equitable and efficient. These are the statement of the quality metrics which must be maintained in an obstetric anesthesia. Say quality matrix, it carries 6 points, mostly the first three. What is the best practice for mode of anesthesia for cesarean sections? These are the according to ASA guidelines. They say general anesthesia for cesarean delivery should be avoided when possible, but also initiated when indicated. Because when you are definite indication for general anesthesia, you do not restrain it. And then there is the next is the possibility of the management of the blood pressure and
Excuse me,
hypotension.
sir. There is some
Given
distortion in your voice.
the hypotension-induced hypotension during the earliest 20.
Excuse me, sir.
Yes. Oh, no, no sound is clear again. I think there is some
No,
net
sir.
issue,
It's
I
a bit
think.
distorted. It's distorted. And we missed the last two slides because of that.
Okay, I can go back. This is the ASA quality matrix. Now it's okay, or I have.
So better.
This is the ASA quality matrix. This comprises of 6 components: the mode of anesthesia for cesarean and neuroaxial induced hypotension, response to request for the liver analgesia, opioid consumption, and PDPH accountability and labor epidural replacement rates. These are the different 6 in an obstetric anesthesia unit which must be monitored and observed as a quality matrix. And because when you measure these things, then you can improve, quality improvement will come next. The first best factor for the mode of anesthesia section is the general anesthesia for cesarean delivery should be avoided when possible, but also initiated when indicated. General anesthesia avoided, but when there is a clear-cut indication of general anesthesia, you should not refrain from it. And then there is a management of hypotension, neuraxial induced hypotension, blood pressure, frequent monitoring. Heart rate must be assessed before spinal anesthesia, because what is the baseline heart rate and the systolic blood pressure within 10% of the patient baseline blood pressure. And the phenylephrine infusion or norepinephrine infusion is also recommended strongly. As in the last previous lecture of the PSA, the doctor said that this is the recommendation. And intravenous colloid or crystalloids, there is no concept of co-load. There is no delay in the spinal anesthesia concerning the preloading. You must co-load and then give the spinal anesthesia. And then left lateral uterine displacement is also important, because it will also hinder the venous return, and it will definitely when the management of hypotension must be considered. Next best practice is opioid consumption. Opioids consumptions must be maintained for only for rescue or breakthrough pains. Opioids must be, and other wound infiltration and facial pain block should be, and multimodal pain management should be the mainstay of that. And the response to any reflex of neuraxial anesthesia within 30 minutes of the maternal request, or in exceptional circumstances, between 1 hour, this is another in labor analgesia exceptions. According to the post-dural puncture accountability, the needle should be 25 gauge in obstetric patients, or less or more, are strongly recommended, or small gauges. Post-procedure visit should be 24 to 40 hours must be done. And if the PDPH develop, it must be treated in an obstetric unit. This is no, it must not be treated in an emergency department or in any other department. These are the quality metrics which are defined by the Royal College of Anesthesia. These are different standards which must be maintained in an obstetric. Accidental dural puncture must be less than 1% of the different procedures done, regional neuraxial procedures. Epidural catheter recited during labor less than 15%. Adequate pain relief within 45 minutes. Start of procedure must be 88%. A request of epidural analgesia already the same. Patient satisfaction with labor analgesia must be more than 98%. And for category 1, they also 30 minutes and 75 minutes for the delivery of the baby. And other is table below show rates that will be expected in the average unit, which may be used for benchmarking. What category of cesarean should go for regional or general anesthesia? There must be some benchmarking. These are the benchmarking table below shows. The category 1 cesarean sections, more than 50% must be carried out under regional anesthesia, and general anesthesia should be carried out less than 15%. And the category 2 and 3 cesarean section must be carried out more than 80% in the regional anesthesia, and the category 4 cesarean section must be more than 95%. The conversion to general anesthesia rate in category 4 is less than 1%, which is a benchmark. to maintain anesthetic anesthesia units, and in the category 2 and 3 is less than 5 in case of emergency. The conversion of general anesthesia is less than 15 is the benchmark in anesthetic. Now, next few minutes, we are going to discuss what are the different guidelines for the post-operative cesarean pain. This is the procedure-specific guidelines, prospect guidelines regarding cesarean section. This is the important guidelines which are different according to procedures, different procedures. What they suggest, regional anesthesia you use, if you use intrathecal morphine is used, 100 mics can be used safely. An alternative for if you are using epidural catheter, to 2 milligram regional morphine can be used for post-operative pain. For systemic multimodal anesthesia, paracetamol is usually recommended preoperatively, intraoperatively, and NSAIDs are usually recommended after delivery. And then you can continue it post-operatively. IV dexamethasone is also recommended after the delivery of the patient, especially, and in some cases, if concerned to the blood sugar level of the patient is also there. Then the local analgesia techniques post-operatively, if intrathecal opioids are not used, then you can go for the local anesthesia and wound infiltration. You can go the continuous infiltration or single shot, facial plane blocks, tab block, quadratus lumborum block, rectus spinae block. These three of the blocks are all recommended. The tab block is less invasive. Quadratus lumborum is usually a little more invasive. We in our setup usually go for tab block in the post-cesarean period, and we have very effective patients of the tab block for post-operative pain relief. Surgical techniques is usually on the surgical domain. Then the incision line, Johann Cohen incision. This is usually a conventional fenestrine incision above incision दिया जाता है. It's above the fenestrine incision. Non-closure of peritoneum and abdominal binders. These are the surgical techniques which will result in less pain. Analgesia, joints and rescues, TENS is very effectively used post-operatively, and the opioids are usually reserved for the breakthrough pain and the rest. These are the different type of cesarean section. This is the midline, and this is the Joel Cohen incision, which is usually above the fenestrine line. This is usually causes less pain as compared to the fenestrine. Now we are going to discuss some best practices in worst scenarios. Best practices in ideal rate of cesarean section lies between 10 to 15%. Now, in recent, there is this rate of cesarean section is no more in the quality metrics, I must tell you. But the cesarean section in the lower middle income countries or in the poorest quintile of countries, the cesarean rate is only 3.5%. There is a marked difference in the women are deprived of cesarean section. And it's mostly the main reason is the shortage of anesthesiologists. I have told you there is a worldwide deficiency of anesthesiologists there. WHO recommends that cesarean delivery should be available to any woman who requires it rather than aiming for a specific rate. So there is no ideal cesarean section rate, but up till now that this is not in the any quality metrics of the obstetric anesthesia. But usually the WHO says that 20 to 25% cesarean rate is acceptable, because when you go beyond this, then the maternal complications are more. Best practice in cesarean section is increasing globally, and there is surgical and anesthetic practices this is the presence of the anesthesiology is very much important, and one best neonatal outcome, maternal and neonatal outcome. For this, there is one study is done, which every study with the title "Every Second Matters" with the ketamine essential surgery ketamine package. This study was done in a lower middle income country in Kenya in 2021, and this study give a training to for 5 days training, and they use the ketamine in where there is no anesthetic. And what they found, that this ketamine package can be used by trained non-anesthesia providers to support emergency cesarean sections when no anesthetic. Ketamine has a significant potential to increase access to emergency cesarean deliveries in resource limited settings. In resource limited settings, and when there is no anesthesia available, ketamine can be used. In Pakistan, in the periphery, if you go beyond 10 years, the ketamine is extensively used by the non-anesthesia providers, but now it is used a lot. Anesthesia, this is a disclaimer in this study that anesthesia must be provided by a specially trained anesthetist who has access to necessary medicines, infrastructure, support, and equipment. And however, it is not the current reality. The training of the law, thousands of anesthetists is not possible in a resource limited setting. So it is alternate to emergency cesarean surgery is often death, and it is particularly devastating as two lives are lost. Now we are coming the worst scenario. What is the worst scenario of a cesarean delivery you found in an emergency is the perimortem cesarean delivery, also referred to as resuscitative hysterectomy. This is incidence is very much high, especially in the war zone areas. It is usually 1 in 30,000 in pregnancies, 1 in 12,000, and especially in the Gaza and the Ukraine in the last few years, there is a lost non-survivable trauma. There is a lot of perimortem cesarean deliveries were done, and this is provision of high quality CPR and the relief of aortic compression with the lateral nutrient displacement. The goal of perimortem cesarean delivery is to improve the maternal and the fetal outcome. That if the baby is out, then maternal and fetal outcome will be better. Ideally, perform perimortem cesarean delivery within 5 minutes. Usually, you can go you have four minutes of CPR, and then in the next 1 minute, the baby must be out. If the patient is not improved, the role of extracorporeal CPR according to the latest guideline is there. If you have the facility to go ECMO, then you must go for the survival of the baby and the. Now, this is another study role of TIVA in anesthesia. This is there is some case series which are being done and reported in the literature, and this is some new. The TIVA is definitely latest and advanced and has many advantages over the general anesthesia. The role of TIVA, this is a Metro Day study. What is this? Is usually this is done in International Journal of Obstetric Anesthesia, and they've what found that TIVA is less effect on the uterine tone, less postoperative nausea, vomiting, and more environment friendly. But there is some anesthesia depth monitoring must be there, must be done in a high income setting. And the volatile anesthesia have different issues like post anesthesia, vomiting, that contribute to greenhouse effect, dose dependent uterine relaxations. And MAC is can be assessed to use the anesthesia depth monitoring. This is an advantage of the volatile anesthesia. So the TIVA in cesarean delivery incidence and maternal neonatal outcomes, usually in a tertiary units, use of TIVA in obstetrics has been described, but very small cases and series, as I told you, especially in the high-risk patients, just like cardiac diseases, malignant hyperthermia, a study from the UK investigating GA techniques in which they use in high-risk patients 0.7% of cesarean deliveries, they use the propofol as a maintenance dose in other than the inhalation anesthesia. And they also found very more advantages as compared to the inhalation anesthesia. This is a one study which is European Journal of Anesthesia and Intensive Care Medicine. This is comparison of cesarean section bleeding between volatile and the TIVA in Japanese national database. And they also found that volatile anesthesia associated with a higher risk of bleeding as compared to TIVA. But no comparison is of the TIVA is there with the neuraxial anesthesia. This is in another research hype. If anyone can't go for the TIVA in general in cesarean section, especially in emergency, if you have, but TIVA also requires a lot of time to set up. If you have these techniques set up available in an urgent time, then you can proceed with TIVA in emergency. Now, last slide, take home messages from me. This is the consider the time available, the wish of the participant, and your skill. These are the three important: the time available and the wish and your skill. Communicate with others, talk to obstetricians, discuss with the obstetrician how much time is there and how you can proceed. This is very important. But do not give the decision of the type of anesthesia to the obstetrician. It must be decided by the anesthesiologist. Be self-critical, decide on GA early. If these things are not going well, go for GA. Urgent situations are very stressful, and the patient usually provide patient support, explain each step to the patient, and she knows what to expect, because there are a lot of cases of reporting of the postpartum depression and suicidality. This is due to because the patient is really unaware of it, not told anything. Even in the high-income countries, psychiatric illnesses are more. Neuraxial anesthesia is usually preferred to general anesthesia for cesarean delivery due to less in maternal morbidity. Small gauge pencil point needles are preferred due to the prevalence of the PDPH in the obstetric population. Hypotension must be managed with a phenylephrine infusion. It is recommended. Now, an oxytocin is usually recommended as in just 1 to 3 international units intravenously, then followed by a titrated. And this is thanks. These are my references which I used from the mostly I took the WAFSA lectures and the WAFSA articles. And this is the last article I must tell because we have different guidelines and different timelines available, but really the human factor in anesthesia is very much important. How we'll create a safe culture in the operation theater that nothing wrong will be done to the patient. The development of the safe culture is very important. The leader, who will lead the OT and who will in a crisis situation, who will lead the situation and how will you manage this? This is a very important article. This is open access. You can easily go. Thank you.
Thank you very much,
Also,
sir. That was a wonderful session, and we appreciate your time and the effort that you have put. Uh, there is a question in the comment box. Meanwhile, if any of you have any question, you can comment here. Uh, just one question for now. At DG Fan, ephedrine and phenylephrine are not available. Are they available at Lahore, Multan, and Bahawalpur? Somebody has, Dr. Haqdar Durrani has asked this question.
sir, phenylephrine is actually available, I think. So ephedrine is sometimes short. Phenylephrine is freely available. Phenylephrine is we are using in our OTs. Phenylephrine is freely available. Ephedrine has some shortage issues.
Any of the seniors in the participants, I would like you to share your thoughts and experiences on this. Uh, we have another question. Uh, the role of dexmedetomidine in emergency C-section.
Yes, we have studied some cases. There are some cases in which the intrathecal dexmedetomidine, but it also depends on case-to-case variation and your skill. If you must use dexmedetomidine in other than different cases, then you can use it intrathecally. I did not found any study, and we are just planning to initiate a study. We are now, for trial purposes, we are using dexmedetomidine in our setup in cesarean emergency cesarean sections. Uh, 3 to 5 mics can be helpful, but it all depends on the situation of the patient and the scenario of the patient. Whether you because it causes hypotension, hypotension is the major concern. Your patient dexmedetomidine in a patient with a low volume status is disastrous. So you must, if your patient is volume filled, then you can go easily with dexmedetomidine because it causes very less hypertension. But in this scenario, this is all the situation to situation variability. But there is also studies are going on in dexmedetomidine.
One more question. For eclamptic patient, what is the anesthetic technique?
This again depends upon the scenario. If the eclamptic patient, if the eclampsia is done, this is definitely if the GCS of the patient is not accessible and the patient has revived from the eclamptic cesarean, then you can proceed with that. If the parameters are low, there is no contraindication, especially the thrombocytopenia associated and there is bleeding and coagulation profile allows you, then you can go with informed risk and your scenario. If you have an post-operative ICU availability in your setup for a management of patient after GA, then you can go. But this all depends on your own skills, your availability of the resources, and your availability of the patient condition of the patient. When I am working in services hospitals, some people are doing eclamptic patient in regional anesthesia, but it varies upon scenarios. If there is a patient with continuous grand mal seizure, then you cannot go for regional anesthesia in such kind of patient that frequency is high. If a patient is come to the emergency after controlled magnesium infusion, you think the patient, the fits are quite controlled and his GCS is reversed, then you can go for regional anesthesia, provided there is no contraindication.
Thank you. There is another question. Dr. Jamshed Khan has asked if he had a patient brought to the OR in obstructed labor with just one arm delivered. Uh, I proceeded with GA. What is your advice?
In case of the prolapse, any body prolapse, if this again a discussion between an obstetrician and the anesthesiologist, if they support from the below and the patient is stable vitals, and you are expert in such kind of patient, the position of the patient for regional anesthesia is very better. If your patient is vitally stable and the, if they are supporting the limb with the supporting, then you can go for regional anesthesia in lateral position if you are expert in. It all depends on your expertise and patient's condition. If your patient is properly, you can go for rapid sequence spinal in this patient. You can simultaneously co-loading, and there is no other risk factors. Just then, depending on if you are expert in spinal anesthesia and lateral position, then you can go because it will cause less burden on the prolapse organ.
Okay. Another one. Berhamul Hassan has asked, should we give GA in eclamptic patient for neuroprotection?
For neuroprotection, GA, I don't think GA can help in GA can help in if this. I don't think any neurosurgery can you can put the patient on GA. Or not
Okay.
one thing you can the hemodynamical stability is important. If you are going, your patient is hemodynamically unstable, then you can go that in GA in there are more control as compared to regional anesthesia. Because in regional anesthesia, when you are given the drug, then you have to be there on the headline of the patient because in GA you have more control. You can titrate GA. In regional anesthesia, titration is not possible. I think hemodynamics more matter if you are going to go for the GA. In a neuroprotection, I don't think so is an indication for general anesthesia.
All right. There's another question from Dr. Farzeen Shah. General anesthesia relation with depression is related with some specific drug or generally related with it?
It is the attitude. Is the study was done actually. The Mowbray study, the UK, I have referenced in 2019. Even there in the UK, the attitude and the explanation to the patient at that time is very. They have found it very. It's not up to the mark or compassionate. And this attitude of your patient was not properly explained the situation. And if the situation changes in any setup, the patient was not properly pre-informed. Because there are nearly 60 pages consent before proceeding any in UK and in Canada. Despite all these, the patient is not just satisfied. Because patient, you are not talking to the patient at his patient level or what he is expecting. Simple procedure, the covering of the patient in awake patient in sheets, this can also lead to this is not associated with any drugs. This is the sequence patient is passing out. In Pakistan, there's also a lot of post cesarean depression, post pregnancy psychosis cases are reported. And it is not related to any drugs, I think. So.
Right. So we are taking one more question. Can we use 0.5% bupivacaine for subarachnoid block instead of hyperbaric? Suhail Parvez has
Yes,
asked.
in the rapid sequence spinal, I have told you this is used 0.5% hyperbaric 3 ml. You can use 0.5% hyperbaric depending what are you going to get from the dad. Actually, the most important is at what level in a static patient. I missed a slide in that I have just gone through. At what level you are injecting is very much important. The drug is as much not important. If they usually now recommend the use of ultrasound to find the L2 level. You are must be below because in pregnant patients the lumbar vertebral level is very difficult. So they recommend the use of ultrasound to get not go above the L2 level because in some cases your point of insertion of needle is above, at the L2 level or above L2 level, which will result in a higher block. That you can go with 0.5%. But at point as in the clinical practice, I have came to know the 0.5% as little bit slow onset. It's all depend on the timeline. The hyperbaric, you can go if you go introduce hyperbaric, you can use position. Some persons, some practitioners still using the position to get an effective flow.
All right, sir, we will take one last question. And for the participants, I have shared the feedback form. You can fill the form so that you can get your certificate. The question is, would you advise opioids at induction when delivery can be done in few minutes by cesarean?
Not at all, not at all. This is not recommended at all. Why are you giving opioids at delivery? Because this is a general rule. Everything which crosses the blood-brain barrier will cross placenta, definitely. Then, if you are giving opioids too early, opioid must be given after, or even benzodiazepines must be given after the cord is clamped. Because if your priority is mother, if there is indication of the cesarean is something else or is simple hysterectomy in case of intrauterine death, then you go if there is not concern. But if your concern is the neonate and the outcome and the patient condition, then you must avoid it opioids before induction.
Very well, very well summed up, Shahid. I must add here that the use of opioids in cesarean is definitely has always been discouraged ever since, and for the live baby, I don't think so. It is worth the anesthetist to think about it. Very well presented. Thank you.
Thank you, ma'am.
Uh, Thank you very much, sir. Thank you for such an insightful session. And I thank all of the participants for joining in. And that I think we will conclude this session for today. The feedback form is in the comment box. You can get it from there. Um, that's the end. Thank you very much.
Thank you. Thank you.
Oh, sir, can I have just a question to continue this? If the patient is having pain at the start of C-section, what is the best drug?
What is the best done? It must be, and
Drug.
this is what is the best drug. This is very wrong thinking. Whenever there is a pain, we think for the drug. You must assess what kind of pain is there. Is there is anxiety level? Is there is a definite pain level? What is the level of the spinal anesthesia? Did you check the before incision started? Did you check the level? There are different options in case of elective cesarean section and in case of an emergency. In case of emergency section, if you have the patient has a definite pain and your level is not properly achieved, one thing is you can wait. If there is no wait is not an option, then you can change the position of the patient. If you can usually if there is you can after assessment of the pain, if there is a definitely a pain threshold is very much high and this is a definitely pain, then you can convert it to GA rather than using different drugs for different purposes. First, the most important in this process is the assessment of the pain. What be compassionate to the patient, assess him, just divert him from the situation after discussing few things. If he can proceed, most important is what anesthesia level did you check before starting of the surgery. It is if it is there, then there can be done easy. If any doubt, then you can GM must be in your alternative. If you can think because it's a law, it's a 20-30 minute procedure. You can't manage it with IV drugs if the patient is having.
Thank you very much, sir. Thank you for really expanding the knowledge. And that's with that we conclude the session. And for the participants, the feedback form is there in the comment box. I have shared it multiple times. You can fill the feedback form, and the certificates will be sent to your email. And that's all for today's session.
Good. Thank you.
Thank you, sir.